All right, well, good evening, and thank everybody for joining us this evening. So the field of neuromodulation has really exploded in the last decade. Patients and clinicians have an abundance of choices when exploring options for stimulation as a part of their pain care. And not only have the number of devices multiplied, but the clinical applications for these devices have expanded quite a bit as well. The technology holds great promise for many individuals who are living in pain, as it can really help reduce the symptoms that they're experiencing and improve their overall quality of life. And certainly, many of us who are working in the field of pain have seen this firsthand in the patients that we treat. But one of the things that we've learned over the years is that while patients may get benefit from unimodal care, so while they may get benefit from just a stimulator device, their overall outcomes are truly maximized when we employ a multidisciplinary approach to treatment. So today's webinar is going to focus on how we can maximize neuromodulation outcomes through multidisciplinary care. And we're going to specifically focus on the medical, physical, and psychosocial components of treatment. We have experts in the field that are going to be discussing each of these areas from their clinical perspectives, and then we're going to have time for questions from the audience. For the questions from the audience, what we ask that you do is there's a Q&A function on Zoom here, just toward the bottom of your screen. We just ask that you type your questions into there. And you can type your questions anytime during the webinar. We're not going to answer them during the presentation, but at the very end, we'll have probably about 10 minutes for the questions where we'll go through and answer those one by one. But with that, I'll go ahead and introduce each of our presenters. The first person who's going to speak with us tonight is going to be Dr. Justine Pearl. All of our presenters, excuse me, are delightful individuals, and she is a neurosurgeon who specializes in chronic pain and brain tumors in Northern Michigan. I'll speak to you all next. I'm a pain psychologist. I'm not as delightful, but I am a pain psychologist at University of California, Davis, practicing in our pain center there. And then we'll be rounding out with Craig Smith. Dr. Smith is a physical therapist and co-founder of the Smith Performance Center in Tucson, Arizona. He specializes in long-term rehabilitation for complex pain and injury cases with the focus on bridging the gap between injury and real-world function. And so with that, I'll turn it over to Dr. Pearl to lead us off.
Awesome. Thank you so much, Dr. Prasad. It is so nice to be here. Thank you so much for having me, and I'm really grateful to be on this very esteemed panel. So I do consult for Nevro as an education consultant. A bit about me, I am a delightful neurosurgeon working in Northern Michigan, and I do quite a lot of surgical management of pain, including neuromodulation. And one thing that I think is a bit, sorry, I just want to time myself or else we could go all night. A bit unique about my practice is that I do basically all of the surgical side of things from beginning to completion, meaning I screen the patients, I perform their trials, I do their lead pulls and their assessments, and then I also do the permanent implant if it gets to that. So I think I have a bit of a unique experience to offer as a neurosurgeon, just being a part of all the different facets of the process to getting this particular implant. So what I wanted to do with my time, and of course, very welcome for all kinds of questions, is to talk about some of the things in my practice that I have found enhances my personal surgical outcomes within, the bigger construct of knowing that the neurosurgeon or the person implanting these devices is really just one cog in the wheel of what should be a large team managing this complex problem. So I chose to divide things into the before, the during, and the after. So from the surgical standpoint. So essentially the before, so when you're essentially just first meeting a patient and hearing about their chronic pain journey, the first thing I really focus on is being present. As a neurosurgeon, this is something that, is always trying to be taken away from you, that initial encounter, that clinic, non-surgical billing encounter. And I really won't let it go because it really is so critical to be present when you are deciding whether or not to perform a surgery on a patient, even though these are, minimally invasive and the rest of it, it is so critically important to have that initial encounter where the patient actually can look you in the eye and know that this is the surgeon or the proceduralist or what have you that is going to be taking care of me, and start that relationship building. And the next thing I really like to do is really analyze everything that happened before me. And that is not, a detailed record of every single pain or injection or medication or solve that was ever tried. What we're looking for here is really what has been tried, what have the responses been, what has the consistency been like, or the lack thereof. There's value in knowing these things about a patient that you're considering offering a potentially life-changing, better or worse surgery to, in any surgical situation, quite frankly. So I think it's really important to make sure you have a sense of what's been tried, what hasn't been tried, and what were the responses to it. What not, and I'm not necessarily as interested in what was every single functional gain made in physical therapy, or what issues were tackled necessarily in pain psychology, but was there consistency? Did the patient show interest in that process or a lack of interest? These are all valuable things for us to know when we're taking care of a 360-degree approach patient. And again, none of these things are to screen a patient away or for. This is just getting to know what makes that patient tick. Because if we don't figure that out, it will be very difficult to treat their condition that's as complex as something like chronic pain. The next, I think, the last thing I have on my slide is actually comorbidities, and that's sort of, a no-brainer, so to speak. Obviously, these are important things that we need to think about when deciding if a patient is safe to undergo a surgery and if it's the right thing for them. So that's obviously something that we think about really closely. And again, not to rule anyone out, but to see how we can best support their needs in this journey whilst keeping them safe. But by far the most important thing that we do in this before picture when we're getting to know someone and trying to figure out what the best option for them is education and managing expectations. I usually say less is more. I'm a big fan of things that are elegant and minimally invasive, but when it comes to managing expectations in patients that have chronic pain, this is critically important. And I think it's even more so important because the system sometimes sets you up as a surgeon or as a pain doctor, or as whatever have you, for failure. The pain patient is often a dejected patient, a patient who may be suffering with depression or anxiety or the rest of it. And they come to you, the system is set up that you have to do all of these different things, and not just do them but fail at them, not have great results, and then you get to see the surgeon, and the surgeon is going to evaluate you and come up with some kind of surgery for you that's going to fix everything that ails you. I mean, even if you wanted to involve a neurosurgeon sooner, it's sometimes very hard the way different insurances work and the like. It really is, well, have they tried everything? Have they done this, and this? Not even thinking, well, what is their pain pattern, and was what they tried ever going to help them? Instead it's just, well, it didn't work, and now you can see the surgeon, and now we're going to offer you a procedure. And that's a really hard patient to see, because you desperately want to help them, with every fiber of your being, and they desperately need help, because again, if they're in my office, they presumably failed all these things that were supposed to work, and they haven't. So now you have to now best manage that complex, very dejected patient in front of you. And the tendency, of course, is that you want to help, and you think that maybe with your scalpel you can help. And that's unfortunately something that has really become rampant in pain culture, but that is why it is even more important to spend that time and get to know exactly what the pain means for the patient, and what exactly has already happened before you, and what exactly are they looking for in the future, and managing those expectations about what you realistically can offer based on everything you've been through, the history, the physical exam, the imaging, the provocative maneuvers, all the things. So the most important thing, like I said initially, is really being present and not passing that time off, and making sure that you are getting to know what makes the patient tick, because ultimately that is what is going to drive everything that happens thereafter. So we can go to the next slide. Um, which is talking about the during. And again, the first point that I would always make is to be present. These are not things that you ever want to farm out or not be a huge part of, because as the neurosurgeon, we have that level of expertise. And although there are multiple members of a good multidisciplinary pain team, there aren't redundant members, which means that there's no one else necessarily on that team that can offer the patient your perspective, both about open surgery, about what is the best option for them, about neuromodulation. So again, during the surgery, be present. And then when we talk about, surgical technique and the importance of meticulous technique, I think it's a really important point that I take for granted, but I also was trained as a surgeon. So things like nuances, tissue handling, surgical planes, incision planning, these are all things that we take for granted, but are really important in any patient, and especially the chronic pain patient who may have already had several surgeries, who may have already had different things, different maneuvers or manipulations that may make things challenging or difficult, different as the surgeon. And so it's really important to think about these things, and we do. When we think about, from a surgical standpoint, if you were to ask me what are the two largest volume kind of complications or failures that you see, it comes down to two things: infection, right, and lead migrations or complications. And these are important things that we have some degree of control over in the operating room. And everyone's protocol, if we talk about infection, everyone's protocol is going to be a bit different. But I think what's more important is that you have a protocol, that there's an understanding amongst the people doing these procedures and amongst the centers doing them, whether that's a level 2 trauma center like where I work, or a smaller ASC where multiple procedures are being done, that there is an infection concern, that these are implants. In my OR, it's essentially a joint precautions. We don't allow excess traffic in and out of the room. It's a closed neuro team that knows how we like it done. It's like clockwork every time. There's a consistency there, and there's value there. And so that's just one example of things that we can do to minimize infection. From our point of view, we notice that the most common place that people get infected is the generator. So we made a protocol for, insertion of the generator. So I work with a nurse practitioner, and she usually handles the generator site while I work on the leads. So for instance, there's really no one in and out of the room. The generator is opened 30 seconds before we need it. So it's not just sitting there idly, as 40 people are, running around trying to get things organized for the next case or whatever have you. My nurse practitioner, changes her gloves. She's been helping me get leads in and do things there. And so she changes her gloves, and she actually never handles the generator. It's always with a sterile Raytec. Everything is done in that manner. And then, of course, we happen to use vancomycin powder at the end. Different centers use different things, antibiotic, irrigation, and the like. Another really important thing is the minimizing the use of cautery. These are, or should be, small incisions, and the more heat we use, that promotes tissue destruction, which can be dangerous in a short surface area. So these are just surgical nuances that should be performed and adhered to every time consistently. And overall, this has resulted in, I don't want to say anything because I'm like a superstitious surgeon, and then tomorrow I'll get an infection, but we've done really well with this type of consistent protocol in terms of keeping our patients out of explants and out of off of antibiotics. So the next thing is the lead migration. So anchoring is really important. And again, I take it for granted, being a surgeon and having that understanding of the planes and what tissues, support lead anchors, and that difference between knowing if am I really suturing to fascia, or did I catch muscle? If we're catching muscle with our anchors, I've noticed a lot of times that can result in a lot of postoperative pain for the patient when they move. Every time they move and the muscle twitches, the anchor pulls. So little things like that, making sure that we're in the right tissue planes, exploiting the planes, um, you know, reverting to a midline incision. I think a lot of people do these paraspinal incisions, and sometimes, if you're not used to it, you can easily get lost. Um, and then just in terms of, a good undermining of fascia to bury those anchors. If you are someone that sutures anchors in, that'll both prevent them from having palpable pain, which again, we're supposed to be helping their pain. We don't want to give them new pain. And it will also minimize the chance of lead migration. So these are the things in surgery that I'm just constantly thinking about to make sure that I am doing my part to maximize this patient's outcome, as a part, still in the context of the greater team that is helping this patient. I think we can go to the next slide. So after, shocking, be present. So this is actually one of the most important times to be present. I think there's sometimes a culture in surgery where we're trained to do surgery, so we do the surgery, and then someone else in the clinic kind of does the majority of the follow-up. And I really would say, in my practice at least, that is not how we do things. No one will really understand the wounds or what was done like the surgeon will, or like the proceduralist will. So maintaining that involvement post-operatively in the really slam dunk easy good cases, and the ones that end up being more challenging, it's critically important to be present and to follow up with these patients as much as they need, to be able to assuage any of their fears or concerns regarding surgery and surgical outcomes. Maybe in pre-op you told them that the wound could conceivably be tender for like 4 to 6 weeks or longer, especially if it's a fibro patient or something like this, but they don't remember because they were really stressed out and nervous about undergoing anesthesia or whatever the case may be. And so you may need to just revisit with them, hey, this is a separate thing from the stimulator. Actually, your neuropathy is doing great. Now, this incisional pain, let's talk about that. So it's really critically important to maximize their outcomes and their success, to keep those lines of communication open. The questions and the concerns don't stop just because the surgery is over and done with. So that is something that has served us very well. When I say ensure perfect healing, I know that there are certain factors in our patient population that predispose them to healing. We do this procedure with great success on patients with bad diabetes, and we know that patients with bad diabetes often have trouble with wound healing. So that is not what I'm trying to say, but it doesn't mean that you can't preemptively involve the wound clinic or give your friend on the floor who heals with a lot of wounds, a lot of ulcers, and the rest of it, and just have a conversation about what things you can do to maximize the wound healing, and what things you can do to help the patient through the wound healing process. So again, none of our goals here on the surgical side are to ever take away a procedure from a patient that could benefit from it. Quite the opposite. It's making sure that those patients get the benefit without any undue stress or harm, because then we're just adding a plus and a negative, and we haven't really gotten anywhere, and that's at the expense of patient care, which is obviously not allowed. So the last slide, I think I'll lock it up and give it back to Dr. Prasad. At the end of the day, no matter what we do from the point of view of our surgical interventions, if we aren't working with our teams, and we're not employing a multi-plane or a multidisciplinary approach, then I fear that no matter how brilliant, or delightful a surgery was, the patient ultimately at the 2-year mark, let's say, will not have those outstanding, long, durable outcomes that we pray and crave for our patients. So there's no better segue than to turn it over to Dr. Prasad to talk about some of the other nuances that go into a successful outcome. And thank you so much for listening.
All right. Well, thank you very much, Dr. Pearl, for sharing those pearls with us. So, when discussing psychology and neuromodulation, people are often very familiar with the role that psychologists play in pre-procedure evaluations. But contrary to how it may seem, those psychology evaluations are really much more than just a checkbox or a hurdle imposed by insurance companies. When completed properly by an appropriately trained clinician, these psych evals can actually yield very useful information regarding comprehensive treatment for patients that look at that longitudinal picture that Dr. Pearl just talked to us about. Furthermore, that patient selection process, the information that's gleaned from the eval is critically important to assist with that patient selection process. There's reviews that found that poor outcomes are associated with psych factors in over 90% of studies that were reviewed. So psych factors certainly play a significant role. And these are the cases where you look at your procedure, you look at the films afterwards, and you can see that everything was technically perfect, but the patient doesn't have functional gains. They don't have the outcomes that you want. And that's the things that are related more to those psych outcomes. So the pre-procedural screening is certainly important. But I'm not going to talk about that today. Those are things that I often talk about at the annual conference. I often give a lecture on pre-procedural screening. Oftentimes at the labs, I speak about that. Today, I'm going to talk more about the role of psychology in maximizing treatment outcomes. So once somebody has had a device put into them, where does psychology fit in the overall treatment process? But why is this important? Well, for starters, there's no treatment modality that we have across pain that results in 100% elimination symptoms. All of us wish that we had that magic wand or that magic bullet that would eliminate pain for our patients, but unfortunately, we don't have that, right? And even with neuromodulation, I mentioned at the start of this that the technology has advanced quite dramatically in the last decade, and the relief that patients get is quite superlative, and it's really amazing to look at. But even that doesn't result in 100% elimination, right? But let's say, for argument's sake, let's say that a patient gets a dramatic outcome from spinal cord stimulation, from neuromodulation. Let's say that they have 85% improvement in their symptoms following the procedure. Well, they still have 15% of their symptoms that remain. So how do they manage that residual 15%? How do we make sure that that 15% doesn't become all-consuming, such that they're back to a point where now they're obsessed about that residual pain and they're no longer functional because of it, right? Now, there's some aspects of pre-surgical patient selection that can help to make sure that we identify the right candidates that won't have that tendency. But even still, what can we do to make sure that a patient is able to manage whatever residual pain they have? Well, so for this, we need to make sure that we take a different treatment approach to care. Because we're not able to fix pain, the next best approach that we have is to help patients learn how to manage their condition. So this management approach to pain is similar to the approach that we take with any kind of chronic condition that lacks a cure. Heart disease, diabetes, asthma, all these conditions, we don't have a way that just makes these conditions go away, but rather we help patients learn how to manage their conditions, maximize their functioning, maximize their quality of life. And that's the function, is to focus on quality of life and functioning. But when I say this, when I share this with patients and talk about this management approach of learning how to live with pain, many patients have a hard time conceptualizing what this means. And actually, when I present this, even at medical conferences, many physicians and clinicians also have a hard time kind of grasping what this means. So the next few slides is meant to illustrate what this concept is supposed to accomplish. So let's say that this square represents your life. You go to a family reunion or you go to a class reunion, somebody asks about your life. What are the things that you talk about? Well, typically we talk about friends, family, work, our leisure activities. You might talk about that great webinar that you went to on a Wednesday night, right? But these are all the different types of things that fill our life and that give our lives meaning, right? One day, a pain condition sets in. And by definition, starts as something acute, and it takes center stage in our life because it's something new, it's something acute. We do investigation to try to figure out what it is, and we do our best to try and eradicate it. But even though this pain condition is there, we still have space in our life for all those things that give us meaning. Over the course of time, as this pain condition transitions from acute to chronic, as it fails to respond to the treatment modalities to make it go away, we start to see disruptions caused by the pain. We start to have decreased activity levels, pulling away from work activities, increased work absenteeism, not going to family events, not going out to social activities, becoming more isolated. This can lead to increased emotional distress, depression, anxiety, frustration, anger. And with some of those, it's not necessarily even a clinical diagnosis, but just as we define those words in the dictionary. People can start to have sleep disturbances, difficulty falling asleep, staying asleep, or getting a restful night's sleep. And that can be because of the pain. It can be because of the emotional distress or their treatment for those. People can have increased number of doctor office visits. It's not uncommon to see individuals living with chronic pain have frequent visits to primary care, emergency department, specialty care. And inevitably, they can start to have conflicts in their interpersonal lives as they pull away from life activities, as they have increased emotional distress. They can start to butt heads with the individuals around them. And as they do less, they can become more physically deconditioned. But now you ask a person about their life, a person living with pain about their life, they're no longer talking about their life, but they'll start talking about a new procedure they're going to try, a new doctor they're going to see, this newfangled device called a spinal cord stimulator, a new approach to treatment, neuromodulation that holds out great promise for helping them. They're no longer telling the story about their life. They're telling the story about the pain's life. But it's easy to understand how that transition occurs because the pain starts to radiate out and overshadow all those things that give somebody quality of life. So the goal of our treatments that we have, whether it be neuromodulation, psychological interventions, physical therapies, is to help decentralize the role of pain in a person's life, eliminate a lot of that distress that's been caused, and help people get back to a place where they have space for the things that give them meaning. We unfortunately can't eradicate pain 100%, but that doesn't mean that it has to be the central focus and continue to result in all those impairments. And so this is the goal of helping to help patients learn how to manage their pain. But to get from this to this doesn't involve just a single unimodal treatment. It really requires us to embrace a shift from a purely biomedical approach to a biopsychosocial approach that embraces the psychological, biological, social components of a person's experience. And in the context of pain, this involves a multidisciplinary approach to care. We have to have that medical optimization where the physician, be it a pain specialist, a surgeon, nurse practitioner, physician assistant comes in. That's looking at all aspects of the medical care. Is there a role for implantable therapies? Is a person on the most appropriate medications for their condition? What other injection therapies or treatments may be available to them? That's all the medical optimization. Physical reconditioning. And we'll hear from our colleague, Craig Smith, speaking about the role of physical therapy in these cases in just a bit. And then lastly, behavioral and lifestyle modification, which is where pain psychology fits in. And so I'll quickly go over what we typically do as psychologists in this realm. So as psychologists, we focus on helping patients learn how to shape a lot of the behaviors that we know that can influence their day-to-day functioning. So we provide patients with, in the education that we provide patients, whether it be an individual setting or group format, we provide them with an overview of their pain, help them understand what's going on in their body when they experience pain. We teach patients how to approach activity patterns. Patients, if they do too much, they pay for it. If they do too little, they pay for it. So how do they find that fine line between doing too much and too little? And this is particularly important after somebody has a device placed in them because we want to make sure that they don't just abandon whatever activity regulation strategies that they learned that allowed them to be more functional. We teach patients about the relationship between stress and pain. How does stress make pain worse? And what can they do to influence that relationship? We know that life is inherently stressful, but given that we know that stress also makes pain worse, it stands to reason that the more tools a patient has in their toolbox to navigate that relationship, the better equipped they'll be. Relaxation training is one example of one of those tools that we teach people. We also address sleep, ways to improve a patient's ability to fall asleep, stay asleep, get a restful night's sleep. And that's critically important in the realm of pain and something that oftentimes doesn't get addressed nearly enough. We teach patients how to identify stressors in their environment that can influence pain and how they can address those things, communication skills, and flare management planning. Help patients know that whatever they do, these aren't cures for their pain, but how do they manage that residual pain that's still going to be present in those inevitable flares? Typically, this education occurs in class or group formats because it tends to be more efficient, and it also helps break the sense of isolation that patients feel when they're living with the pain condition. Just being in a room or in a Zoom room with others who are trying to learn how to manage a condition can break that sense of isolation. Now, there's a lot of evidence that supports using these different types of treatment modalities. And I'm going to start with a study that's actually pretty old. It's a 25-year-old study. And so you might question, wait a second, why does PSPS have a webinar that goes over an old study? You'll see why I'm going to go over an older study in a second. Linton Anderson had patients who had back pain receive regular treatment versus cognitive behavioral treatments. And they had pre and post test measures that were done at the beginning of treatment and at 12-month follow-up. They found the risk of long-term disability, in this case, they called it long-term sick absence, was 9 times higher in the group that did not have CBT. And the CBT-based group had decreased medical utilization compared to the other groups. Now, the reason why I like this study, even though it's an older one, is because it looks at the durability of cognitive behavioral therapy interventions in pain. The same population who participated in the study was surveyed 5 years later, and they had a 97% completion rate and found that the people who participated in the cognitive behavioral therapy had significantly less pain, higher activity, better quality of life compared to the people in the minimal treatment group. They had less lost productivity cost and lower long-term disability. Bob Gatchell and his colleagues put a cost on the benefits of cognitive behavioral therapy. And in their study, they identified people who are at higher risk for long-term disability using a wide variety of different factors, placed those people in an early intervention program, and found that participating in that cognitive behavioral program at an early intervention resulted in improved outcomes. But not only were functional outcomes better, but there was a reduced savings in total medical care of roughly 41% for these individuals. Cognitive behavioral therapies have also demonstrated significant efficacy in helping patients to successfully wean off of opiate medications. And then we saw this particularly when the opiate crisis was at its peak. As you start to pull people off opiate medications, if you just take that medication away but don't give them any other tools to manage their condition, they're not likely to be successful. So we want to make sure that as we take that tool away, regardless of how effective it was or not, we replace it with other tools that patients can use to manage their pain. And so this is, again, where cognitive behavioral therapies can be effective and have shown their effectiveness in helping patients successfully wean off meds. And one of the last studies I want to go over is a study that used literacy-adapted cognitive behavioral therapy versus education and treatment as usual in individuals with chronic pain. The reason why I like this study the most is because of the data sample that was used by Dr. Thorne. Many studies, to have a high quality research, they typically have sample sizes that are comprised of people that have pain in one site, no psychiatric comorbidities, and no other pains in the person's body. That is not typically the kind of patient that comes into a treatment center for pain. But in Dr. Thorne's study, she had 290 participants that had pain in more than 2 sites, more than 6 sites, excuse me, greater than 4 pain etiologies, pain present for more than 15 years. And what she found was when you compared usual care to CBT and pain education, when you looked at pain severity from baseline to 6-month follow-up, we actually didn't see dramatic shifts in pain severity. Now, you might say, well, that's not really a great ringing endorsement for cognitive behavioral therapy. But again, the goal in cognitive behavioral therapy is not necessarily to address the pain itself, but improve quality of life and function. And when we look at function scores, we see that cognitive behavioral therapy compared to usual care certainly does start to produce more significant changes. And certainly when we look at depression scores, we see changes as well. But cognitive behavioral therapy, these different psychological treatments, they're not just having people change their thinking, but these are actually associated with changes in structure and function of the brain as well. Studies have been done that show that different regions of the brain have changes in their structure, changes in the function when people participate in cognitive behavioral therapy. But interestingly, in randomized controlled trials, they found that pain education did not produce these same changes. So there's something about cognitive behavioral therapy and the extension that has over pain education that creates these changes. But there's more beyond CBT. Cognitive behavioral therapy is kind of the gold standard for many psychological-based interventions, but it's not the only evidence-based intervention we have as psychologists. Biofeedback training, acceptance and commitment training, mindfulness-based interventions, emotional awareness and expression therapy, pain reprocessing therapy, all of these have robust evidence to support their use in patient care. So in conclusion, psychological interventions are a very important component of interdisciplinary pain care beyond just patient selection. There's a lot of evidence-based psychological interventions that we can use to maximize function, and the selection of the approach is something that we do that's very patient-specific. But this is just one component of that multidisciplinary approach. The other component, which is very important and critical, is physical therapy. And for that, I will turn it over to my colleague, Craig Smith, to round us out for the evening.
Thanks, Dr. Prasad. So, like I was introduced earlier, I'm a physical therapist out in Tucson, Arizona. I have a couple clinics out here. I also do some work helping to build out clinical processes and basically using clinical findings to improve people's outcomes. If you want to go to the next slide. I don't have any disclosures or anything like that. And so what I was hoping to go over is just kind of the physical therapist perspective on neuromodulation. In a lot of ways, the way that we think of it is actually very similar to any time we're not actually having a good result with the patient. Is we want to make sure that we're actually doing everything we possibly can to make the person get better. But like Dr. Prasad said, not everything works. And so when somebody comes in, we want to give them the best shot, stay as positive as possible, rule out things that we know that we can actually handle and do a really good job of hopefully improving their function, reducing their pain, understanding what type of triggers are driving their symptoms, really get a really good clinical picture of what's going on with the person. But then also understand when something's not working, we want to make sure that we actually are able to get support and get help. And that's often where we bring in referrals. And for me, my background, I worked really close with pain physicians when I first started as a physical therapist. Have done multiple projects, research projects, and things with them. And it's very helpful and supportive to actually be able to work with pain docs to help have better outcomes with our patients. And one of the biggest things that we look for is if we start to see a lack of progress, we start to see central modulation issues, we see that even if they're moving better, they still feel terrible. Those are times that we start to build the idea, okay, we're going to probably want to refer if they don't already have that relationship with a physician who has referred them to our care. You want to go to the next slide? Now, honestly, once you start going through the process, depending on what insurance, we don't take insurance at the clinics that we have, but when I have had to use insurance, sometimes this is actually limited. But when possible, we want to actually support the physician as they work through other levels of care, whether that's trying out medication, doing injections, going through the phases to determine if this person's actually appropriate for implantation. One of the big things that we try to stress during this time period is that really setting the expectations of what's going to happen. Like a good outcome would be greater than 50% improvement in their symptoms. Because sometimes what happens is they'll think when they get the procedure, they're going to be completely pain-free. And then, like I said, some of the worst outcomes that I've seen have actually happened when the person had the best response to the implant and they went out and then just totally blew themselves up, had some type of issue with the implant. I mean, there's a lot of expectation issues, and that actually people who were well educated at the beginning, they were able to handle some of the ups and the downs that happened during the course of rehab. So it's really just getting them ready for once that procedure is actually done. I'm going to go to the next slide. We still view, once the implant's done, our team still views the surgeon and the pain physician as the quarterbacks. And so we try to use whatever the most up-to-date protocol or tool that they recommend, especially for early management for the first 6 to 8 weeks. We really try to implement the plan that makes the best outcome and make sure that we don't basically screw up and push the person too quickly. One of the biggest issues that we run into and what we really want to handle is they're basically lost some of the pain that would tell them not to do things. And so we don't do an immediate push for exercise, even though oftentimes you might have somebody who's like feels ready to do more and more and more. So we really want to focus on, if possible, getting restoring inhibitory tone, getting better central modulation from the PAG. The whole idea of if somebody's been physically inactive, we understand that comes with loss of inhibition of motor neurons at the spinal cord level things like that we want to actually start to reintroduce, light cardio, light activity that they tolerate really well, and start to regain functional movement. Let me go to the next slide. Now, our team uses we call a 3 capacity model. One of the reasons that we use this is it really helps to clarify for the patient what their actual focus is and what their actual limitation is. And we view there being basically 3 basic capacities that each of the patients have. And this actually works really well with most clients who come in who've had a long-standing injury. That's going to be energy capacity, tissue capacity, and exercise capacity. Energy capacity, you can kind of think of just as fatigue and fatigue response, which I'll go to in the next slide. Tissue capacity, we think of as pain and tissue response, and then exercise capacity as performance. Now, one of the biggest issues is going to be that people will have typically, even with this type of an issue, they'll have an exercise capacity that's considerably higher than what their tissue capacity is. And that gap is their ability to just hurt themselves really, really well. And what happens when we have somebody come in is we actually don't know oftentimes where their level of tissue capacity is. And so we'll use tools basically to determine what it is. And then tissue capacity in our clinic, we call it the rehab standard. It helps people to understand the focus of their exercise, the focus of their PT is actually to feel good afterwards. It's not to sweat and work really hard. It's that they have a really, really good response to the treatment that's done. The energy capacity issue, what we find can actually be just as triggering as overloading the tissue. And that's when we have people who have complete breakdowns and just energy crashes. And that can be from multifactorial, multiple issues that can drive that. And we'll use scales like the multiple dimensional fatigue scale and things that like a energy trigger, an energy checklist, basically go through and see if there's any reason why they're basically bottoming out. But what we want to do is we want to set it to whatever thing is the worst. So if they come in and their energy is completely zero, we really want to try to get their energy level to increase, and that's going to be the focus of their workouts. Whereas if it's tissue capacity, it's going to be really doing everything we possibly can to make it so that they can tolerate more activity without having a bad response. You want to go to the next slide? Now, what you can see here on one side of the slide, you see where it says daily activity intensity. That's not static. And oftentimes individuals won't understand that it's not static. They'll think that every single day that they do is basically the same day repeated, and that's often not the case. And so we actually look for what's called a yo-yo effect, where they say they feel great, then the next day they feel horrible, and the next day they feel great, and the next day they feel horrible. And what can happen is they don't recognize that they're doing high intensity days, and then they have a bad response to that, and then they have a low intensity day, they feel like they recover. And it's really useful basically for us to be able to map that out. And we often do that over the course of a week and lay out what's the actual intensity of their day, not just with physical therapy or with any exercise that they're doing, but in its totality. Literally last week, I had an individual who was doing significant amounts of yard work and did not understand that that's what was causing their symptoms, because there was no real increase in physical therapy intensity, and they were just blowing themselves up. And so it's almost like a blind spot, but it's really understanding what the intensity level is and what that's required for that day, and then really setting the intensity level to what your tissue is going to have a good response to. One of the things that we can do things like artificial stabilization or tools that basically artificially increase their tissue capacity. You can do things like core coordination exercises to make sure that they're actually protecting the segment that maybe hurt. Give tools that basically allow them to handle the activity at a really high level. You can go on to the next slide. One of the more useful tools that we find that helps to just give the client, the patient, a really good understanding of what a good response is, that's not just tied to pain, but also tied to a feedback loop, is we call it the tissue response level. So level 1 just means that it shows up during the activity. For us, we're talking about baseline, and I'm not saying that they're going to be completely pain-free, but if they have a significant increase in pain, we already know that they overloaded their tissue capacity in some way. We want to modify it so that it's well tolerated. Level 2 is that they feel worse after the activity. Level 3 is later in the day. Level 4 is the next day up to 72 hours. For example, these individuals, especially once you have not done physical activity for a long period of time, they're high risk for late onset muscle soreness, which can then trigger off a whole bunch of other symptoms. 5, end of the week, so that's where we're looking for cumulative load. And then 6, which is typical for anybody, which is why you always need to build in some level of recovery inside your workouts and exercise, is basically at the end of 4 to 5 weeks that they feel like they need a recovery week. Using those languages tied with actually a pain response or pain increase is really useful because it gives them tools to be able to basically figure out their own patterns. And that's kind of an overview from a kind of high level, but long term, the way that our team recommends doing it is transitioning from a physical therapy mindset to, we use strength coaches to basically take them out of a medical mindset where they're actually focused on their performance, but we really try to get their tissue capacity and exercise capacity to match first.
All right. Well, thank you very much for the physical therapy perspectives. And so with that, uh, Dr. Pearl, myself, and Dr. Smith will take questions from the audience. We have just one question from the audience so far. And so Brandy put in here that she performs evaluations, but it's not connected to the team with the performing neurosurgeons. How do we get patients back in for psych treatment to optimize treatment outcomes? What I would say for that, Brandy, is when you do the evaluation, at the time that you do the pre-surgical evaluation, if there are recommendations that you have for the patient's care in terms of psychological treatments to help optimize their outcomes, I'd recommend that you talk to the patient about incorporating those in their care at that time and kind of build it in starting from the point of that evaluation. Depending on the nature of the practice, unfortunately, many places the care is fragmented, where the clinicians who are putting the devices in, be it the neurosurgeons, the pain specialist, they're oftentimes not connected to the psychologist who's doing the evaluation. And so in those cases, what you'd want to do is you'd want to try to set up that care beforehand. And also what you may want to do is meet the surgeons, go out and interact with them. It's really important for the clinicians to know who the other folks are, who's authorizing or evaluating these patients. And the better the professional relationship that people have, that the psychologists have with the folks that are putting the devices in, the better off you are. The more you can understand why somebody gets rejected for a device, why somebody gets approved, what the comfort level is of the clinician who's putting the device in. So beyond just kind of talking with the patient and setting that up at the beginning, from a larger perspective, I'd recommend connecting with the surgeons or the implanters and forging that relationship. But Dr. Pearl, as a surgeon who puts these devices in, what would your feedback be?
Yeah, that is perfectly said. There's the initial psychological evaluation is so important, and you don't necessarily know who this person is. I enjoy the experience of getting to know your colleagues and sort of understanding their rationale and their approach. And sometimes we have to almost outsource our psychological evaluations, and that is not always the best option, in all honesty, because you don't really have any consistent relationship with someone that can, that you can ask questions to, but that can also give you feedback about each particular patient case that they're seeing, and have that ongoing kind of symbiotic relationship. So I know that if there was, this is something we looked for, we were dying for someone local that wanted to kind of partner with us on that end to do it. So that's amazing that there's an interest there.
I guess it helps if I unmute myself before I ask the question. What about from a PT perspective in terms of the relationship with the device implanter?
Well, I think it's very useful to understand if there's any precautions and just to, I know that it's physical therapists in general, we're going to have a lot of different types of procedures and cases that come in. And even if you're deeply used to doing it, we may not be. And so it's really useful to have just even if it's this is the exact device that we use, this is what I'm most concerned about. Um, Even like the most basic information and what would be the biggest thing that we can make a mistake on, just because it's we don't want to overload somebody. We don't want to set back something that could be so useful and helpful for the individual. I think that's probably the most useful thing that we're able to get, and that there's open access if something starts to seem sideways. Like if we start to feel like there's a um, we always recommend before undergoing surgery that you always have, who do you call if something starts to look like it looks wrong, or you start to feel sick, the infection, all those things. And for our team, we try to get that written down, because we typically do a lot of, like Justine said, a lot of prehab before the person actually undergoes the procedure. And we want to make sure all those are there, and we also want to know that we have that number as well, because we'll call with the patient. So those types of things, just where we can be the most helpful, and where can we make sure we don't make preventable mistakes.
Thank you very much. And there's another question in the chat about familiarity with culturally informed CBT, chronic pain interventions for diverse communities. I would actually take it a step back beyond just the culture informed CBT to say that all of the care that we provide, whether it be the physician based part, the PT based, or the psych, we need to make sure that all aspects of that care is culture informed, because how a patient interacts with us, how they respond to treatment, how they access that treatment is going to be informed by their culture and unique cultural factors. And so I would say that pretty much all of the care that we do, we have to make sure that in the forefront of our mind, that we kind of keep that in mind, but not just the patients that we see, but patients in the community who perhaps we're not seeing because of cultural related factors, who have pain. And so we also want to be thinking in the back of our minds, how do we try to reach people who have pain, who could advantage themselves with some of the therapies that we have, but who may not be able to because of some of these different cultural reasons, and what might we be able to do to reach some of these individuals. So I would actually say that taking that framework is so important, and it can be challenging in this day and age. There's a lot of issues that come up as you use words such as diversity, culture, competence, things along those lines. But I think that when it comes to just science and evidence-based practice, there are no bad words with that. The science clearly states that there are differences, and we need to respect differences across different cultures, and we need to make sure that we meet people where they are at. And culturally sensitive, cultural appropriate practice is the appropriate way to go. But I'm curious about my colleagues' perspectives on that, in terms of the kind of that more global Gestalt perspective.
Yeah, I mean, I would just say from our standpoint, it's yeah, it's hard to know when you're not, like, if you're in like a bubble. Like I know that for us, like the things that we run into, um, and we actually have to, we basically help, we actually get used to working with other facilities and support people who actually can't pay for it, pay for our care. But it's actually quite a bit more difficult than I would have expected across our different clinics. So when we have insurance, it can be a barrier to people being able to come in from if they're in Arizona, like, on access, to people who are afraid of medical professionals for a variety of reasons. So the biggest thing is we try to reach out as much as possible, right? Try to talk about and normalize discussions around pain, which can be a very difficult issue. So yeah, it's more just trying to give as much communication as possible, and and support whenever we can.
These are such great points. I think Dr. Prasad saying, meeting patients where they are, that is so critically important. Nothing can really move forward unless we're doing that. And I think from my perspective, I've struggled a lot with helping patients see the quality of life that can still exist, even though the pain is not gone 100%. And patients come in with their own set of wants and goals and expectations. And sometimes that's just biomechanically or physiologically not in line with what is going to be realistic, a realistic rehab, potential for the patient. And it's really kind of forced and enabled me to get better with those harder conversations about how maybe your body is getting older. And I know you don't feel this age, but you're renting a vessel right now that is that age, whether we like it or not, and sort of informing those expectations the patients have around getting older and all the struggle that comes with that. And it's been very eye-opening and enlightening, even as I get older and understand how things feel and look and how that can be different. And so it's really, I think, important from the point of view of the care team to have those sometimes uncomfortable discussions, because if we're not having them, no one else is really having them. And just almost letting people know that it's okay that you can't necessarily do all those things that you did 20 years ago, and that is okay. And the fact that you can't do all the housework you want to do right now, I know that that's a big part of your identity, but that is okay. We can find a path forward from this. So yeah, meet them where they are.
Well, we're wrapping up. We're at our 1 hour mark. And so I would say that the biggest take-home point is that while neuromodulation alone can produce amazing outcomes, we can really maximize the benefits that patients get through use of interdisciplinary treatment. In physical therapy, pain psychology, the medical components, these are all essential parts of this approach. And there's ample evidence that supports use of all three of these modalities. But I want to thank my colleagues for taking the time at the end of their busy days to share their insights. I want to thank the audience members for attending and for asking insightful questions. If you're not a member of PSPS, I'd strongly encourage you to join. There are a lot of great opportunities with the organization. And then also, please mark your calendars for the PSPS annual meeting that'll take place in Las Vegas this September. It's a great place for learning, a great place for networking. There's a QR code on the screen there. Please scan that to get more information. But again, a great place for networking and learning. Strongly, strongly recommended. But with that, again, I thank everybody for joining us here tonight. I want to really thank my colleagues for joining me here, and I wish everybody all the best. Hope you have a wonderful evening and rest of the week.